All right, so the first thing I'm going to start with, because we have a bunch to go through, is manual muscle testing. In manual muscle testing, it's important to note that we grade it as a 5 out of 5, 4 out of 5, and so forth. We go down. And basically what we're doing is we're going to try, if we're assessing 5 for 5, right, which is normal, we're going to move the limb of the muscle corresponding, right, through a full range of motion against gravity, right, with resistance. If they can do that, that's good, that's normal, that's perfect. If they can't, maybe a 4 out of 5, right, which we assess as good, right, means that we're going to move them against gravity through a full range of motion, but with less resistance. If they can't do that, we go 3 out of 5, right, which we denote as fair, or F. And that is moving through a full range of motion against gravity, but we're not providing any resistance. And then 2, right, so they can't do 3, right, so 2, we're going to get them out of that position that we put them in when we're trying to work against gravity. We're going to move them out of that position, and that correlates obviously with the muscle we're testing. And what we're going to do is we're going to move them through a full range of motion, but we're not against gravity, we're no resistance. And if they can do that, right, then that's poor. And then 1 through 5, same thing, same position, right? But what they're not going to be able to in a 1 through 5, they're not even going to be able to move through the full range of motion, but they're going to have a trace contraction. So you'll see the muscle that you're trying to work or you're trying to assess, you might see it contract, right? So it's trace, but they're not going to move that through the full range of motion. And then 0 through 5 is not, that's not good, right? And that means that we can't even get the trace contraction, and so forth. So today, what we're going to be assessing for the lab, or for the practical, is its gluteus maximus, semitendinosus, and tibialis anterior. So let's get into it. So now we're going to assess manual muscle testing, and like we talked about earlier, we have to assess if we're looking for 5 out of 5. We need to go against gravity, against resistance through a full range of motion. So the first one we're assessing is the gluteus maximus. So we're going to stabilize at the hip. We have to flex them to 90 because we want to isolate from the hamstrings. We're going to provide resistance down here at the distal end of the femur, and you're going to work up into hip extension. Good. And then if they can do that, which is a 5 out of 5, we're going to do a break test. So we're going to put them midway in the position, which is the strongest point. I'm going to try to break you out of it, isometrically contract, and don't let me break you out of it. We'll go here, and I'm going to hold, hold, hold. And then we would assess bilaterally. So we would come around here, same positioning. We're going to stabilize up at the hip, provide resistance down here, and you're going to go good. And then she can do that, so we'll do a break test. And then I'm going to try to break you out of it isometrically contract. Hold, hold, hold. And that's the gluteus maximus manual muscle test. All right, so now we're going to be assessing the semitendinosus. So what we want to do is we're going to isolate from the biceps femoris. We're going to internally rotate, and we're going to assess knee flexion. So I'm going to go at the popliteal of the knee, where I'm providing my stability, providing my resistance down here at the distal end of the tibia, and you're going to move into flexion against my resistance. We're looking for a 5 out of 5, so you're normal. Okay. All right, go. Good. And then she can do that, so we'll do a break test. So I'm going to try to break you out of it statically, or isometrically contract. Hold, hold, hold. And then we'll come around, we'll assess bilaterally. Oh, look at you, already internally rotating. And then we're going to put our hand or stabilization on the popliteal of the knee, distal tibia, and you're going to work into flexion. Good, you can do that, 5 out of 5. So we'll do a break test, mid position, strongest point. We're going to do the same hand placement. I'm going to try to break you out of it. Hold, hold, hold. And that's semitendinosus. So now we're going to assess the tibialis anterior, which is working ankle dorsiflexion. So again, we want to be against gravity, so we're going to have her with her feet off the table or whatever surface we're using. We're going to stabilize down at the distal tibia, provide resistance at the forefoot, and you're going to go into dorsiflexion. Good. And then we're going to do a break test. So we're going to put you in the mid-range, and we're going to try to push you out of it. Don't let me push you out of it. Hold, hold, hold. And then we assess bilaterally. So we're going to, again, do dorsiflexion, so provide resistance here, stabilize, and you're going to work against my resistance. Good. And then in the mid-region, don't let me break you out of it. Hold, hold, hold. And so she could do that, so it's 5 out of 5, so we don't have to go 4, 3, 2, 1 down the line, but if we did, we would change the positions, and I talked about those positions earlier. So today we're going to be testing the Achilles reflex. That's the only reflex for the lab practical. A reflex is a simple reflex, meaning when you tap the tendon,
the signal goes onto the spinal cord, jumps onto an effector route, and then it'll go to the muscle causing a contraction. So for the Achilles, we're looking for plantar flexion. So we're going to stabilize the plantar surface right here, and then we're going to look for the Achilles tendon. We're going to use the flat side of the hammer. The only time we would use the pointy side is the brachioradialis, where we would tap our thumb. But so we're going to go here, we're going to find the Achilles tendon, we're going to look for stepping on the gas. Just like that, plantar flexion. We can do it again because it's fun. And then we would want to compare bilaterally, so we'd come over here, supporting plantar surface, taking that flat side, and then we're going to look for plantar flexion or stepping on the gas. And that's assessing the S1 and S2 nerve root.
Great.
So now we're going to be doing an anterior drawer test to assess the ATF ligament, or anterior talofibular ligament, and that is going to be preventing the talus from sliding anteriorly out from under the tibia. And usually in an ankle injury, it would be the first injured, followed by the CF, and then the PTF. So what we're going to do to assess it is we're going to, and if we were assessing for an injury, we would do the uninjured side first just to establish a foundation. So what we're going to do is we're going to go to the plantar surface. We're going to go right here. We're going to do an anterior drawer looking for that stop. And you can see that sudden stop. And then we would assess bilaterally right here. And we can do the same thing. Work anteriorly. And you can see that everything is intact. So now we're going to do the Lockman's test, and that would be assessing the stability of the ACL, or anterior cruciate ligament, and that's just preventing anterior translation of the tibia in regards to the femur. So what we're going to do is we can do a closed pack test and an open pack test. The closed pack assessing the capsule and the ligament, so we would want them in full extension. So we're going to put our hand on the distal femur, and we're going to come underneath, and we're going to be around the proximal tibia, and we're just going to work in an anterior fashion, looking for that sudden stop, as you can see. We would then do a closed pack just to get, or an open pack just to get the ligament itself. So you're going to go into slight flexion mode and relax, and we're going to have the same hand placement and the same movement, looking for that sudden stop. And then we would assess bilaterally. You stay right there, man. So again, we'll do closed pack position, full extension. We're going to come here, and we're going to do an anterior fashion. You can see that sudden stop. And then we could do the open position, open packed, just the ligament, same hand placement, and we're going to work in the same motion that we have. And you can see that our ACL is intact. Then we're going to do Trendelenburg, which would be assessing gluteus medius strength. So I'm going to go to the back. Some people have dimples, not everyone, but I'm going to find the PSIS, posterior superior iliac spine, and then I'm going to have him, we can do both, so we can test both gluteus medius. So you're going to put your right leg into flexion. There we go, and he's still even, so that would be a negative. And then you're going to put, let's try your left leg, and he's even as well. So then with the Trendelenburg test, if he had fallen to his stance side, because what's happening is when you lift into flexion, your opposite gluteus medius fires to keep that balance. So if he had fallen towards his stance side, then he would have had a weak gluteus medius. So now we're going to do Apley's compression, which is assessing the meniscus. So we're going to put them in flexion. We're going to provide stability down here at the distal thigh. We're going to put our hand on top. Support down here. I'm going to compress, pushing the bone ends together, catching the meniscus, and I'm going to internally and externally rotate. And if they had pain, meaning something was wrong, they would report that inside the knee. And then we can assess bilaterally, of course, going into flexion here, and then we're going to compress, and we're going to internally and externally rotate. And that's Apley's compression. Now we're going to do the neuroma test, which is assessing inflammation of the nerve sheath between the met heads, typically between 3 and 4. So what you would do is you're first going to squeeze the met heads together, and this would cause pain. I would say, where's the pain? Like we said, it's typically between 3 and 4. So I'd go to the bottom side, and I could use the eraser of a pencil or my finger. This is the pencil test, and you're going to push the met heads up, and you're going to spread them out, and that would relieve the pain. So then we could come across here to this one. We're going to squeeze. Ow, that hurt. 3, 4. We go to the bottom, and then we're going to push up, and then that would relieve the pain. So like if this was an athlete too, we could put something on the bottom to when they put pressure down, they're separating their met heads and relieving the pain that they have of the inflamed nerve sheath. So for palpations, we're going to start with the CF ligament, calcaneofibular ligament. So it's attaching the calcaneum to the fibula. So we go right here, and it's on the lateral side, and it's straight down in this region. And then we would come over here. If we're doing an eval, we can just compare. So we come down over here, and it's right back here, straight down. So now we're going to assess the lateral femoral epicondyle. So we go to the femur, we assess where the condyles are, and then we're going to move to the epicondyles, which are higher up. Assess on both sides, so we find the condyles, and then we go to the epicondyles, which are further up. So now we're going to be assessing the greater trochanter. So what you're going to do is you're just going to pop out, and it's right over in this region right here is the greater trochanter. And then if we go to the other side, just to get a comparative, right here is the greater trochanter. All right, so now we're going to do pes serene. So the first way we find it, we're going to locate the tibial tuberosity. We're going to put the IP joint of our thumb, and we're going to go oblique medial, 45. So oblique means 45 degrees. And then where the tip of our thumb is, or our thumb pad, that's pes serene. And that's the goose foot insertion for sartorius, gracilis, and semitendinosus. And then we can come over here to compare. Here's your tibial tuberosity, putting my IP joint, and right here is your pes serene.
Yeah.
So now we're going to assess the fibular head, which is, the fibula is a posterior lateral bone, and it's for muscle attachment. And we're here, obviously posterior lateral. We're going to palpate. Right here is fibular head. And then on the same side over here, same thing. Right here is fibular head. So now we're going to do the inferior tib-fib joint. So we're going to find, down here we can find the distal end of the fibula, where the tibia ends, and right in between here in this region is the inferior tib-fib joint. And then we would assess bilaterally, same thing, the fibula, tibias, and right in here is the inferior tib-fib joint, where the interosseous or interosseous membrane is.
3.
All right, so now we're going to palpate the adductor tubercle, which is the insertion point for the adductor magnus. So the easiest way to do it is to come over here. We're going to find the condyles. We're going to find the femoral epicondyles, and then right here behind it is the adductor tubercle, insertion point of the adductor magnus once again. And again, if we're doing an eval, we could just compare both sides, so we can find our condyles, our epicondyles, and right in here, adductor tubercle. So now we're going to assess the deltoid complex, which is down by the medial malleolus, and it's in this region right here. And then right over here, same area, deltoid complex. So now to palpate the navicular tubercle, which is the little bump off the navicular bone, we can come right here. It's right here on the right foot, and then it's more prominent in some people than others. Here it's really prominent. You can see right here, navicular tubercle. Now we're gonna palpate the MCL, so we find the joint space, and then we work medial, and then once we pop out, that would be the MCL, and then we do it on the right side. So we find that joint space, and we work our way out, and then once we pop out, right here is the MCL. Now we're going to do the triangular subcutaneous and the peroneus brevis insertion, which is the styloid process at the base of the fifth metatarsal. So for the subcutaneous triangle, we just come down here to the fibula, or the distal end of the fibula, and we work our way up. And once we stop feeling the bone, we start feeling that muscle, because it is a bone for muscle attachment. That would be the end of the triangle. So the triangle would extend to about right up here. And then over here, just if we wanted for comparative reasons, we could walk our way up the fibula, and then right when we stop or we get off of it, we get that muscle. And that would be the end of the subcutaneous triangle. And then we could also do the peroneus brevis insertion, which is the base of the fifth metatarsal, the styloid process right here. And then over here, base of the fifth metatarsal right there. So now we're going to be doing myotome testing, and myotomes are a muscle or a group of muscles with similar function innervated by a single nerve root. So we're testing for the practical. We're going to do L1, L2, which is for hip flexion. So we're going to come here, we're going to stabilize at the hip, and down at the distal end of the thigh, I'm going to have you raise into flexion for me. Good. And then we would assess bilaterally, so I can get a good mechanical advantage. And then we're going to go here. Good. Next we have L4, so that's dorsiflexion. So basically what you're going to do for me, Miley, is you're going to raise your toes. All right, you're going to raise your toes to the sky. So I want you to raise. Good. And we'll go over here. All right, I'm going to raise. Good. All right, continuing with myotomes. So we did L1, L2, and L4. We're going to do S1 and S2. So for S1, it's plantar flexion, eversion, and hip extension. So we can, while she's sitting on the table, we can assess plantar flexion and eversion. So you're just gonna put your toes up and you're gonna push down into plantar flexion. We're assessing bilaterally. Then we can do eversion, so you can move into eversion, move against. Good. And then if you lie on your stomach or prone, we're gonna do hip extension. So I would support here at the hip, mid-region of the tibia, and you're just going to go into hip extension for me. Good. And then we'll come on this side to get my mechanical advantage, as you would say, Professor Donahue, and go into hip extension. And then that would be S1, S2, knee flexion, popliteal knee and distal tibia, and you're going to go into flexion. Good. And then popliteal of the knee, distal tibia, and you're going to go into flexion. And that would be assessing the S2 myotome.
All right, so now we're going to assess dermatomes, and dermatomes are a skin area innervated by a single nerve root. They're coming off the dorsal side of the spinal cord, unlike the myotomes that we did earlier, which came off the ventral portion of the spinal cord. And then to assess, we're going to do light touch, deep touch, and pinprick. And it's important to note that typically we want to have our patient, or who we're performing the test on, close their eyes just to take away any potential visual cues. So let's get into it.
So now we're going to be assessing dermatomes, and dermatomes are a skin area innervated by a single nerve root. So the first one we have is L2. And L2 comes off about the mid-thigh, and it comes around here. So you're going to, if we're assessing, you're going to close your eyes, and I'm going to do light touch, deep touch, and then pinprick. Could you feel all those?
Yep.
You can definitely feel the pinprick. And we take the vision out of it because we don't want them to get any visual input. And then next we do L4. So L4 comes across the knee, and we can use the tibial crest as our divide line. So we're going to stay medial to medial malleolus. And we'll do it at the same time to assess. So close your eyes. We're going to come across the knee. We're going to go down, and we'll go to the medial border of the foot. And then we would do, we could do our deep touch. So deep touch, can you feel that?
Mm-hmm.
Deep touch,
Mm-hmm.
deep touch.
Mm-hmm.
And then we would do pinprick, pinprick,
Mm-hmm.
pinprick,
Mm-hmm.
pinprick,
Yep.
pinprick. So now we're going to assess the L5 dermatome, which again is a skin area innervated by a single nerve root. So L5 is going to begin, and I'll tell you when to, what I'm going to do, but I'm just going to explain. So L5 is going to start below L4. It's going to work down to the anterior tibial crest, dorsum of the foot, and then some textbooks have it going to the heel. So we're going to assess by light touch, deep touch, pinprick. I'm going to perform the test, and I'll say same, right? And if you feel it good, you're going to say yeah. All right? So you're going to close your eyes to take out any visual cue. And here we go. We'll start with light touch. Same.
Mm-hmm.
Same.
Yep.
Same.
Yep.
Same.
Mm-hmm.
And then deep touch. Same.
Yep.
Same.
Mm-hmm.
Same.
Yep.
Same.
Yep.
Same.
Yep.
And then we can do pinprick.
Mm-hmm.
Same.
Yep.
Same.
Mm-hmm.
Same.
Mm-hmm.
Same.
Mm-hmm.
Same.
Mm-hmm.
And that would be assessing the L5 dermatome. So now we're going to assess S1. So S1 is out of the lateral thigh, lateral knee to lateral malleolus, and then lateral border of the foot. So you come out here. Her eyes are technically closed. It doesn't matter. She can't see. So we're going to come down. We're going to do soft touch here to lateral side to lateral malleolus, lateral border of the foot. Could you feel that?
Mm-hmm.
And then we could do deep touch. Can you feel this?
Mm-hmm.
Deep touch, and then we do pinprick, 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 pinprick. Could you feel that?
Mm-hmm.
We do S2, which is assessing medial posterior of the thigh to the popliteal space, and then we're going to jump to medial gastroc head, and then we jump down to the medial longitudinal arch. So we can start. She is not getting any visual input. So we can start with light touch here. Can you feel that?
Mm-hmm.
Here we're assessing bilateral because we're assessing at the same time.
Mm-hmm.
Medial gastroc head, and we can jump down to medial longitudinal arch.
Mm-hmm.
Then we would do deep touch. So we're going to go here,
Mm-hmm.
here, medial gastroc head, and then jump down, deep touch. And then we do pinprick here, here, knee against our head, and you can jump down. Do you feel that? And that would be the assessment of the dermatomes. All right, so now we're going to assess peripheral nerves, and when we're looking at the sensory innervation and the motor innervation. So the first one we have is we have superficial perineal, which is the lateral compartment of the leg. So it's peroneus brevis, peroneus longus. So our sensory function, or sensory test, is going to be the distal anterior 1/3. So I'm going to have you close your eyes like we did for dermatomes, and I'm just going to do a light touch. And you're going to tell me, do you feel that? And then we would assess the motor function, eversion. So I can go here, and you're going to just move your foot into eversion against my hand. Eversion, good. We assess bilateral, and move your hand against, same thing, good. So now we have the tibial nerve. So for the tibial nerve, it innervates the deep and superficial posterior compartments, the deep being Tom, Dick, and Harry, and then the superficial being the gastrocnemius, the soleus, and then plantaris we talked about with Dr. Rooney. And basically what we're going to do here is we're going to assess sensory. So we can go, you're going to close your eyes for me, and I'm just going to stroke on your gastrocnemius. Do you feel that? All right, and then we're going to work inversion, plantar flexion, and toe flexion. So we'll try inversion for me, which is just like the eversion we did, but now you're moving medial. So you're going to invert, good. You're going to invert, good. And then you're going to plantar flex. It's almost like you're stepping on a gas pedal. All right, so I'm going to put you up, and you're going to flex down, plantar flexion, good. And then over here, same thing. Just like you're stepping on the gas pedal, push down. Plantar flexion, and then toe flexion. We'll assess bilaterally and flex the toes. Good. And that's tibia. So now we're going to do the superior gluteal. So for sensory, that's gluteus medius, gluteus minimus, and tensor fasciae lata. So we're going to stroke for our sensory innervation. We're going to have you close your eyes again. I'm going to stroke the lateral hip area, so right here. Do you feel that? And then we're going to work hip abduction. So you're going to lie on your side for me. We're going to do both sides, so it doesn't really matter where you go first. Yep. And then you can, if you want, you can keep this here to rest your leg on, like that. You're going to keep it straight because we want to get all of them, the tensor fasciae lata, gluteus medius, and gluteus minimus together. I'm going to stabilize right here, and you're going to lift into hip abduction for me, all right? Lift up. Good. And then flip around for me. We'll do your right. Same position. You can rest, come out straight for me, extend straight, there you go. And then here, and you're gonna go up for me. Perfect. All right, so last but not least, we have the femoral, and that's going to be our sensory innervation, is gonna be our quads. I'm gonna have you close your eyes for me. I'm gonna leg touch your quads, do you feel that? Perfect. And then we're gonna assess for the myotome innervation, we're gonna look at hip flexion and knee extension. So I'm gonna come over here, and you're gonna work into hip flexion. Go up. Good. I'm going to come here, you're going to flexion to assess bilateral. Great job. And then we're going to do knee extension. So I'm going to go here, and you're going to extend your knee out like that. All right, and you go knee extension. Good. And then come here, we'll go knee extension. Good. And those are the peripheral nerves.